So general approaches when you're seeing someone with ears, eyes, nose, and throat complaint. First of all, with any eye complaint, always check for visual acuity. Children 2 and over should be able to look at a visual acuity chart and be judicious when we're prescribing antibiotics. Currently, we have a lot of antibiotic resistant organism, and we overprescribe for URI, sinusitis, that are typically viral causes. And then AOM, there are 2 different camps. Do we treat now or do we wait and watch? So I'll talk more about that in a bit. The key here is a thorough history. It's really important that we ask key questions because in our history, most of the time, 98%, we can pretty much discern what the diagnosis is. In the PE, we conduct a PE and order lab simply to further solidify our diagnosis and further rule out the differentials if we need labs or diagnostic tests. Another thing, when it comes to seeing patients with ear, eyes, and nose and throat complaint, let's make sure that we know how to use the diagnostic tools properly. The ophthalmoscope, you guys learn to use the ophthalmoscope is 6531, not 6531 in your health assessment course. And you should have been able to use that in 6531 as well as the otoscope and tuning forks. Understanding how to use these tools properly will help you significantly in assessing your patients. The first disorder I'm going to talk about involves the ears, the tympanic membrane. This is what a normal tympanic membrane looks like. It's pearly gray. We can see the landmarks. We can see the light reflex. We can see the bone structure there. This is what a normal tympanic membrane should look like. And so I want you guys to embed that in your mind so that when you see a tympanic membrane that doesn't look like this, then you should tell yourself, okay, there's something else going on here. Okay. So if you can remember what a normal tympanic membrane looks like, abnormal will come easier for you. The first disorder we will talk about is the acute otitis media, which is the infection of the middle ear. Typically, it's got a rapid onset. The child's irritable. The child might have a fever. And the younger ones, they might not be able to sleep so well. They're fuzzy because they're in pain. They're uncomfortable. And sometimes they might have some ear pulling. Sometimes with the older children, they might complain of some hearing loss or some muffled sounds. And then they sometimes complain of a sense of fullness. What do we see in the physical exam? Typically, I like students to learn how to use the BOLT, the pneumatic otoscopy, to see if there's any movement with the TM. Typically, someone with acute otitis media will have a dull and reddened tympanic membrane. Sometimes they're red, sometimes they're yellow if there's a lot of effusion behind the tympanic membrane. And they're dull. And this is what it typically looks like. As you can tell, you still see the light reflex, but it's a bit dull, and you see the redness here in the fullness of that behind the tympanic membrane. It's bulging. If you recall earlier what a normal tympanic membrane looks like, you compare it to this, you know there's absolutely something going on here. And what that is an infection of the inner ear. It's bulging, it's red, it's dull. How do we treat it? How do we before we go in there, what are differentials? Otitis media externa, mastitis, dental abscesses, trauma, impacted teeth, and TMJ. These are differentials to consider with the acute otitis media infection. Typically, the most pressing issue for parents is the pain for the kids. So you want to manage the pain. Some warm compress, some cold compress on that ear to help manage the pain. And also, is the child a candidate for antibiotic therapy now? Or is it watchful waiting? I've provided here, you can pause the video to review the algorithm. As you can see, with the symptoms AOM and the child's less than 2, they recommend to treat with 10 days of high dose of antibiotic. For older patients, for older kids, and if they have a fever or severe pain, then we treat with 5 days of high dose amoxicillin. If you're not treating, you observe. And if it's still not better within 48 to 72 hours, or if it worsens or unresolved, treat with antibiotics. Sometimes we've given the parent a prescription for the antibiotic and tell them, fill the antibiotic if the symptoms do not improve in the next 48 to 72 hours. So we call that SNAP. It's the safety net antibiotic prescription. And this left side here, I've provided you a chart of the different antibiotics that we can use. And all of you should have had pharmacology. So you're familiar with these medications, and also you've had 6531. The difference in pediatrics between adults is that all antibiotics should be weight-based dosing, and most of the antibiotics are in suspension, and they have different formulations, such as for amoxicillin. It could be 125 milligrams or 5 cc, or 250 milligrams or 5 cc. So you figure out which solution or concentration you want to use, and then calculate the correct dosage based on the weight. For school-aged kids, it's easier if you can do it BID than TID, because if they're at school, it's really hard to get that midday dose in. So the easier it is for the parents to give the medication, the more likely for increased adherence to therapy. What happens? We want to make sure we manage acute otitis media. Sometimes when it's very severe or there's a lot of fluid there, it can perforate, it can burst. Oops, I skipped a slide here. So we're going to go back to this. And perforated TM can be a complication of acute otitis media. And most of the time it heals on its own. We don't really need intervention. Avoid getting the ears wet. So again, perforated TM can be a complication of an acute otitis media. If it doesn't resolve within 3 months, you want to refer to an ENT. And antibiotic drops if from the acute otitis media. And this is what it looks like. This ear, actually, there's no more infection. It just burst. So we watch and wait. Actually, with this kind of patient, you don't need an antibiotic drop. You just watch and wait and reevaluate. So I want to go back to the previous slide. Persistent AOM can happen if the patient doesn't respond to the full dose of antibiotics. You can also have recurrent acute otitis media when it's greater than, when you have more than 3 in 6 months, or greater than 4 episodes in 6 and 12 months. Make sure you refer patients with persistent AOM to an ENT, because possible complication could be hearing loss, nasoditis, tympanic membrane perforation, and cholesteatoma. The idea here is to teach parents prevention of otitis media. If possible, breastfeeding until 6 months has shown to minimize the risks for acute otitis media. Avoid smoking around the house if they're smokers, and also change out the clothing, because the smoke do tend to stay in the clothes. That's what we call tertiary exposure to smoking. Make sure the kid's up to date with vaccination, the flu, pneumococcal. These are all preventive ways, prevention for otitis media. So educate the parents. So we've talked about perforated TM. Move on here. The next common issue we see is otitis externa. It's also called the swimmer's ear. It is an inflammation of the external auditory canal. It can typically be caused by Staph aureus, Pseudomonas. We get these infections because the area tends to retain moisture. We call it swimmer's ear because typically that's one of the biggest risk factors, the swimming. The chlorine in the pool can kill the normal flora in our inner ear, and hence leads to increased risk for infection, skin infection. What are the typical history? Usually the patient will complain about itching or irritation, some pressure or fullness in the ear. Sometimes there might be a little bit of discharge that might drip down the side of their ear. And some, again, pain. They sometimes will have pain from the pressure. On physical exam, what do we find? We have positive tracheal pain, swollen external auricle canal. Sometimes you'll see some debris. Sometimes the TN was visible, but most likely not. And sometimes you'll see some crusting or pustular lesion. And I talked earlier about staph, strep, and pseudomonas. And sometimes it could also be secondary from eczema, secondary infection, because you have a lot of the dry skin there, the irritation that can lead to swelling in the redness. How do we manage otitis externa? We use ear drops with acetic acid or antibiotic, with or without corticosteroid. Typically, it can resolve in 7 to 14 days. Sometimes if the swelling is really bad, where you can't even see any opening here, I've seen it really, really bad with kids where the swelling, the swelling, you can only see a small opening in the canal. And when you have that, you want to use a wick to deliver the otic drops. If you're not sure what I'm talking about, ask your preceptor. They can show you what a wick looks like. It's kind of small cotton. You put it by the ear and it's basically using the wick makes it easier for the medication to be delivered into the affected area. We don't provide systemic antibiotic unless there are other co-occurring infection. Make sure you follow up in 1 to 2 weeks.